Recording in progress.
All right. So recording is in progress now. So we're rocking and rolling. All right. So tonight we'll be going over Chapter 19, Neurologic Emergencies. All right. Starting off with our National EMS Education Standard Competencies. All right, let's kick her off. So, according to the National Center of Health Statistics, 2 of the top 10 causes of death in the United States in 2015 were neurologic. Stroke is the 5th leading cause of death in the United States after heart disease and cancer. It's pretty interesting. So treatments are based on the type of stroke, if it's ischemic or hemorrhagic. The treatments, they're going to range from more traditional medications for breaking up the clots to new innovative surgical procedures such as a mechanical clot removal in the cerebral ischemia, which is called a MERCI, MERCI, and arteriovenous malformation repair. So arteriovenous, so you can probably get an idea of what we're talking about. Malformation repair. So seizures and altered mental status may also occur when there is a disorder in the brain. Seizures may occur as a result of recent or an old head injury, a brain tumor, a metabolic problem, or a genetic disposition. The altered mental status is common presentation in patients with a wide variety of medical problems. So, possible causes range from alcohol intoxication to head injury to diabetic emergency to stroke. Treatment varies depending on the underlying cause. Neurologic patients can be extremely vulnerable or even helpless. Many of the reflexes that protect an awake person may not function when the nervous system is depressed. The eyelids, they do not blink away dust or irritants, for example. The pharynx does not produce the gag reflex, and the cough reflex is not stimulated in reaction to secretions draining down or a foreign matter in the airway. The body does not seek a more comfortable position in response to compression of a limb in an awkward position. The tongue becomes flaccid, which can cause it to settle back, and then the airway is at risk because of that. So, an anatomy of physiology review, the nervous system is the most complex organ within the human body. I think we've mentioned it on every injury and illness section that we've read over, or chapter we've read over. There has been at least at minimal something said on what the CNS or ANS controls, right? So the nervous system is going to consist of the brain, the spinal cord, and thousands of nerves allowing communication along all parts of the body, right? So it's responsible for fundamental functions such as controlling breathing, heart rate, blood pressure, and temperature. It's also responsible for higher level activities such as memory, understanding, communication, and thought. The major structures of the nervous system are divided into central nervous system and peripheral nervous system. right, we see here we got a setup of the brain. So the brain controls breathing, speech, and all other body functions. Different parts of the brain perform different functions. Three major parts of the brain are going to be your brainstem, your cerebellum, and the cerebrum. The cerebrum is the largest part of the brain. The brainstem controls the most basic functions, like your breathing, blood pressure, swallowing, pupil constriction, things like that. The cerebellum controls muscle and body coordination. It's responsible for coordinating complex tasks that involve voluntary movement of muscles such as walking, writing, and even playing the piano. The cerebrum, uh, the cerebrum is located above the cerebellum and is divided down the middle into right and left cerebral hemispheres. Each half controls activities on the opposite side of the body. The front of the cerebrum controls emotion and thought. The middle part controls touch and movement, and the back part it processes sight. In most people, speech is controlled on the left side of the brain near the middle of the cerebellum. Or, I'm sorry, near the middle of the cerebrum, not cerebellum, cerebrum. So, messages sent to and from the brain travel through nerves. There are 12 cranial nerves that run directly, we've talked about them several times, that run directly from the brain to the eyes, ears, nose, and face. The rest of the nerves join in the spinal cord and exit the brain through a large opening at the base of the skull called the foramen magnum. When your brain swells, it puts pressure on everything that is swelling out, right? So that's why you end up, because of the pressure on the ocular nerve, that's why you end up having blown pupils or one blown pupil. And also, it'll create different issues with your cerebellum because the fact when it starts squeezing or it gets that barrel pressure on it, then it starts to mess up things like your breathing, your heart rate, things like that, because those are your most basic functions, correct? So it's part of your most basic functions. What it's trying to do is, as it's swelling, it's going to go the path of least resistance. So that large foramen magnum is where it's trying to push the brain that's swelling, is trying to push it out through the foramen magnum. And that's why you end up getting the causes. Does anybody remember what we call that? What is the how do we recognize, or what is the term called when we start seeing the breathing problems, the heart problems, and everything like that? There's a certain term that we use, and it's indicative to head injuries. Does anybody remember? You should be able to see this whenever you show up to a crash and somebody's got a head injury. You should be able to recognize that it's a head injury because of some of these symptoms that they're displaying. I know y'all know it. Right. So it's indicative to intracranial pressure. Y'all see, I'm not leaving it alone. I'm waiting for somebody to answer. It's going to be indicative to increased intracranial pressure. All right, so the things you're looking for are for increased pressure of the brain. It's going to be bradycardia. So I was talking about it be heart. No. There's a certain term. It's going to be bradycardia, irregular respirations, and widened pulse pressures. So all three of those together make this certain type of issue. All three of those together. It's a triangle, somewhat. Triangle. Nope. All right. All right, so once I say it, y'all are going to be like, no, not the triangle of death. That's in Bermuda. So once I say it, y'all are going to be like, oh my gosh. Cushing's Triad? Cushing's Triad, sound familiar? Yeah. That's what I was saying, triangle. So Cushing's Triad. These terms, it's just things we use to remember to help us out. To we think of brain injuries, think of Cushing's Triad. Not to be confused with Cushing syndrome. There's actually a Cushing syndrome, and you can actually tell if somebody, you can be a big indicator for Cushing syndrome is something completely different, and a big indicator of that is body habitus, the way their body habitus looks. But it's not indicative to trauma, any type of trauma or anything like that. It's a medical condition. All right. Press on, Ray. What's another triad that we have? Since we're on the subject of triads. Does anybody remember another triad? Yep, Beck's. Beck's triad. And that's gonna be in reference to cardiac tamponade, right? So at that one, you're looking for low arterial blood pressure, distended neck veins, and what's the last one? Anybody tell me the last one for Beck's triad? Distended neck veins, low arterial blood pressure, and there's something else. There's another sign. There's one more. Now, so cardiac tamponade is going to be, it's associated with cardiac tamponade. So if you're thinking of cardiac tamponade, it's squeezing of the heart, right? It's squeezing the heart. There's pressure on the heart. So diminished heart sounds or muffled heart sounds. Good job. Awesome. All right. Y'all got this. All right. The brain. Each vertebra in the neck, back, or at each vertebra in the neck and the back, two nerves branch out. These are called spinal nerves, right? They carry signals to and from the body. The areas of skin sensation corresponding to specific spinal nerves are called dermatomes. All right, what skin condition follows dermatomes? And it can be a very dangerous skin condition. But there is a skin condition, and usually you see it in geriatric patients, that follows dermatomes. And it can start in the back and wrap around. And if it follows the dermatomes, you know that it's this type of, it's actually a nerve condition / skin condition. Shingles. Absolutely correct. Awesome job. Y'all are killing it. All right, neurons and impulse transmission. Neuron is a nerve cell. It's the fundamental element of the nervous system. Neurons are composed of three basic parts: the cell body, the axon, and the dendrites. The cell body contains the nucleus. The axon is a projection from the cell body that extends towards another cell, carrying signals away from the neuron. It looks like the web portion, the web going towards the little ball thing. That's my technical term, the little ball thing. At the axon may or may not be wrapped in the sheath of myelin. Interaction between two neurons occurs at a junction known as a synapse, right? Nerve cells do not actually come in direct contact with each other ever. A synapse is present wherever a nerve cell terminates. So it connects to the next cell via chemicals called neurotransmitters. So the synapse is present where a nerve cell terminates. So it connects to the next cell via chemicals called neurotransmitters. Most neurons use neurotransmitters to transmit their signal across the synapse to other neurons. That's how they communicate. There it is there. Neurotransmitters take the electrically conducted signal from one neuron and relay it to the next cell. Nerve cells respond to these signals by firing or not firing. If you're following along your book, table 19-1, it summarizes the structures of the nervous system and their functions. All right, everybody's favorite, pathophysiology. So there are many different disorders that may cause brain dysfunction or other neurologic symptoms and affect the patient's level of consciousness, or LOC. Speech and voluntary muscle control also can be affected. So the brain is the most sensitive to changes in oxygen, glucose, and temperature levels. Substantial change in any one of these three levels are going to result in neurologic change. When blood flow is stopped, such as in cardiac arrest, the patient will go into what's called a coma, right? A low oxygen level in the bloodstream will affect the entire brain, often causing anxiety, restlessness, and confusion. So other brain disorders include infection and tumor, which may cause seizures, or it could cause AMS, altered mental status, and headaches. So stroke, it's a cerebral vascular accident, CVA, or what we call it, stroke. It's an interruption of blood flow to the brain that results in the loss of brain function. A substantial number of patients who experience strokes either deny their symptoms or they don't understand what their symptoms mean. The longer the stroke continues, the less likely the patient will have a promising outcome, because time is brain, right? Time is what saves the brain. Is it 4 hours? I think it varies. Can't remember what your book says. I don't want to give you the wrong answer. $3 Okay. So that's the way I always knew it, was 3 hours of last normal. So and then depending on what's going on, So a more selective group is going to be about 4.5 hours of last known normal. So that's the important factor when you're doing that. When you're doing that patient assessment, is the last known normal time. So when you're doing that FAST test, for facial droop, arm, what do they call it? Arm drift. What else? Speech. So when you're talking to them and they speak, smile if you want to smile, and you'll see that, what have you, for face. But then also time. Time is last known. So facial, hey, smile for me real big, and it'll kind of be an off smile, and then you'll say, hey, I want you to close your eyes and put your hands out. All right, I need you to hold your hands out straight in front of you, and then one will drift off. That's your arm drift. Speech is you'll ask them to say something, or you'll try to talk to them. You're listening for that the tongue, or the lisp, or the slur. You're listening for slurring. And then at that point, you say, hey, what was the last known normal time? When was your last known normal time? Or who saw this person last known normal? We'll figure this out one way or another. You got to try and figure it out. If they fail any of those lines, F, A, S, or T, or actually F, A, or S, if they fail any of those, then that is a code gray. They are a ruling for a possible stroke. And you gotta get them to the hospital. Give them diesel. All right, so you're not gonna delay your response with a potential stroke. Without oxygen, brain cells cease to function, begin to die. How many minutes? Does anybody remember how many minutes? It's between these two numbers, between this and this minutes, your brain function brain damage is irreversible. 4 to 6. 4 to 6 is usually the big number. You start to get brain ischemia, but you have irreversible after 4 to 6. So dead cells are going to be what's called infarcted cells. Infarcted, dead. An infarction may be prevented from prompt care. You got to get in there quick, and it leads to the restoration of blood in the affected cells. If a small amount of blood is still able to reach the affected area of the brain, it may supply enough oxygen to keep the larger group of brain cells, called ischemic cells. It may keep them better. So if normal blood flow is restored to an ischemic area of the brain in a timely manner, the patient may have less residual damage. They can, yes, because you got to think there's already a TIA is the result of an injury of some sort. So TIAs do cause damage as well. They don't cause as much damage as a stroke, but you're not far from. This is probably going to be the end result at a sooner rather than later. TIA, and then you'll probably move up to the stroke time frame, or the stroke section at some point soon. So interruption of cerebral brain flow may result from a thrombus or a clot developed locally. Arterial rupture, which is going to be a rupture of the cerebral artery. Cerebral embolism. Whoa, that was way off. Cerebral embolism, which is going to be an obstruction of the cerebral artery. It's caused by a clot that was formed elsewhere and then detached and traveled to the brain. There are two main types of stroke. You're going to have hemorrhagic stroke and ischemic stroke. You can see there the varying times of the times versus the signs and symptoms, onset of signs and symptoms. There's a good explanation picture. So ischemic stroke. A blood vessel is blocked so the tissue distal to the blockage becomes ischemic, uh, which is self-limiting pathology. Atherosclerosis in the blood vessels is often the cause. Disorder. It's a disorder. I'm sorry. It's a disorder in which calcium and cholesterol build up, forming a plaque inside the walls of the blood vessels. Is what that atherosclerosis is. This plaque, it may obstruct the blood flow and interfere with the vessel's ability to dilate. Eventually, it's going to cause a complete occlusion of that artery, and the stroke will follow. In other cases, an atherosclerotic plaque in a carotid artery will rupture. The blood clot will form over the disruption in the plaque. Sometimes it's big enough to block all blood flow. Parts of the brain supplied by the artery will become ischemic. Patients often have dramatic symptoms such as loss of movement on the opposite side of the body, confusion, inability to speak. Even if the blockage in the carotid artery is not complete, smaller pieces of the clot may embolize deep in the brain, right? And a cerebral embolism could block blood flow. Look at you. You are wonderful. My wife brought me a coffee in my favorite cup. I don't know if anybody ever watches. Yep. It's one of my favorite shows. That's our favorite show. Sorry. So, a cerebral embolism could block blood flow. Depending on the location of obstructions, the patient may experience anything from a few symptoms to complete paralysis. She knows I've been studying. I started school this week, or started back at Southern Miss this week. So she knows that I've been inundated with I've had enough stick time behind this computer. It's ridiculous. All right, so hemorrhagic stroke. Let's get into that. It results from bleeding inside the brain, typically when a blood vessel ruptures. Severity is going to depend on the location and size of the ruptured cerebral vessel. As bleeding continues, intracranial pressure, or ICP, is going to increase and compress brain tissue. When the brain tissue is compressed, oxygenated blood cannot get into the areas, and the cell begins to die. People at highest risk are those who have chronic, poorly controlled hypertension. After many years of high blood pressure, the blood vessels in the brain weaken and may be prone to rupture. That's why I say you keep up with this high blood pressure, you're going to have a stroke. That's true. It's going to happen. So proper treatment of hypertension, it can help or prevent long-term damage to blood vessels in that case. Cerebral hemorrhages are often fatal. So proper treatment of hypertension can prevent long-term damage to blood vessels and reduce the morbidity and mortality of a stroke happening. People who are born with a weakness in one or more layers are also at increased risk for a hemorrhagic stroke. Aneurysms occur in a few ways, such as a small tear or a defect occurs within the wall of the artery. Blood penetrates between the layers of the artery. Pressure builds up, and the initial small tear increases in size. Symptoms of a hemorrhagic stroke are going to be a sudden onset of severe headache, along with a rapidly decreasing LOC. Sudden onset of severe headache with a rapidly decreasing level of consciousness. So when a hemorrhagic stroke occurs in an otherwise healthy young person, it's often the result of what's called a berry aneurysm. So a berry aneurysm, B-E-R-R-Y, aneurysm. Aneurysm is spelled A-N-E-U-R-Y-S-M. I know that I'll see a bunch of people that'll write everything. Aneurysm, whatever. So a berry aneurysm, just it looks like a berry, right? So it's going to be it resembles a tiny balloon that protrudes from the cerebral artery. This type of stroke is called a subarachnoid hemorrhage. Subarachnoid hemorrhage. Okay. Surgical repair for this is possible. Continued bleeding within the brain will cause the ICP to increase further. Eventually, the brain may be forced out of the cranial vault through the foramen magnum in a process that we call herniation. With herniation, pressure on the medulla oblongata can result in rather bizarre vital signs and other findings, such as Cushing's Triad. Sorry, I went way over the top with that. That must be some really good coffee. All right, so intracranial pressure, or ICP. Hemorrhagic strokes that cause bleeding into the brain put patients at risk for an increased ICP. 3 substances fill the cranial vault: brain, blood, and cerebrospinal fluid. So with increased ICP, the brain may become ischemic due to the lack of blood. It'll herniate. As the ICP rises, the amount of blood available to the brain decreases. Cerebral perfusion pressure, the pressure of blood within the cranial vault, it begins to fall. Herniation is going to be a shift of the intracranial contents within the cranial vault, or displacement of the contents away from their normal position inside the skull. And if you've seen many pictures of strokes, if the ICP, what did I do? Oh my goodness. If the ICP rises sharply or blood pressure falls critically, patients may experience a life-threatening type of issue. Pre-hospital treatment is not effective at decreasing ICP. That's bullshit. Who's pre-hospital treatment? Who said that? Who says that? Bonus round. What 2 types of drugs could be used to decrease ICP in a possible brain injurious adult with an adult with an increased ICP, possibly due to brain injury? Does anybody know that? Nope, that's for breaking up of clots. Yes, it's a possible treatment, but this is a pre-hospital treatment. A pre-hospital treatment that is used in some places. Mainly on helicopters. Does anybody know? Can anybody remember? Anybody ever heard of mannitol? Or labetalol? Okay. Well, thank you. That's a wonderful cup. My wife got it for me. So, mannitol or labetalol, that's just gee whiz information. The key to lowering someone's ICP is in a pre-hospital setting is you don't want to lower it too much. You don't want to lower it too quickly, because if you lower it too quickly, you start to get other issues that come about. So ideally, you only want to lower that ICP by a 10% rate. So in doing so, you make a decision of whether you're going to take labetalol, but it's really hard to titrate labetalol in, or mannitol, and mannitol usually does pretty good for increased ICP. But there's some gee whiz. All right, so this figure is going to show normal and abnormal intracranial pressure. My wife, she works in CAT scan or in CT at the hospital, and they have some awesome cases. They're not awesome for the patients, but they're very good visuals. We'll say that, very good visuals for some of these stroke patients. And there's some of these, like, they have, if any of y'all have Instagram or anything like that, I use Instagram. I don't have friends on there per se. It's all fire stuff, fire information. I like it because there's a lot of good little snippets of information. And one of the things that I always go to is there's a radiology Instagram site that I always go to because it's got different pictures that pop up, a lot of them being stroke, and then it also gives the full workup of this patient. It'll show you the picture, and then you try to see what type of stroke it is, where it's at, blah, blah, blah. And sometimes you can see it like that, and it actually has the moving CTs or the different slices on the CT. It's pretty neat. She likes it because she loves that stuff. She eats that stuff up. She'll sit there and be like, there it is, there's the injury, there it is. And, we see the entertainment value in it because you see through the whole body, each slice, and she can pick out something like that and be like, that's not supposed to look like that. And you could probably put a measurement on it, and she could... I can't do that. But that's her job. Not mine. All right. Miss Hughes is talking about Trans-Ischemic Attack. In some patients, normal process in the body will destroy a blood clot in the brain. Blood flow is restored to the affected area. The patient regains use of the affected region of the body relatively quickly. When stroke symptoms go away on their own in less than 24 hours, the event's called a Trans-Ischemic Attack, or a TIA. Some patients call these mini strokes. Although most patients with TIAs do well, every TIA is an emergency because it may be a warning sign that a larger full stroke is imminent. All patients with TIA should be evaluated by a physician. So here's some signs and symptoms of a stroke. You got the facial droop. You got the sudden weakness or numbness in the face, arms, leg, or one side of the body. You got decreased or absent movement and sensation on one side of the body. You got ataxia. You got sudden vision loss in one eye. You got dysphagia. You got a decreased level of responsiveness. You got aphasia. You got slurred speech. You got sudden and severe headache. You got confusion. You got dizziness. You got weakness. You got combativeness, restlessness, tongue deviation, and also one of the worst ones you'll have is, well, other than death, will be coma. Oh, I spoke too much. There it is. My bad. Man, that coffee's good. We got this Ninja coffee pot. I fell in love with it. One of the guys out in the county, Station 6, they're bougie. Station 6, the bougie station. had this Ninja coffee pot. It's got, it's a real nice coffee pot. Makes it all up for you and everything. It's real nice. And so I came home and I was like, we got to get one. Our what do you call the little coffee pot that puts the little cups in there that destroys the environment? And if you do have one of those, you're probably going to hell. Yeah, Keurigs. So the Keurigs, I'm kidding about the hell part. That's not up to me. I get it because you're lazy and you don't know what good coffee is, so you have a little machine that does it for you. I mean, I get it. So this thing, you put your coffee in there and everything, and it'll make 1 cup, 2 cups, a travel mug, a multi-serve. It'll make a half carafe, a full carafe. I mean, it's got a whole bunch. It'll make rich coffee, classic coffee, over ice coffee, blah blah blah. And it's also got a stir, so you can take it and flip this thing out, and it's got a little machine stir for it. It's absolutely amazing. I heard that, brother. I ain't going to no Olympics either. I did my 3-mile run the other day, and I was pretty sure this. I want to say that I met the criteria for almost half of these symptoms of stroke. I felt like when I got done, because it was my 3-mile run with sprints. The last mile I sprint light poles. I'll sprint 2 light poles, walk 1. Sprint 2 light poles, walk 1. Yeah, it was terrible. You heard about someone else's run the other day. All right. Left hemisphere problems. Stroke in the left cerebral hemisphere may cause aphasia. Aphasia is the inability to produce or understand any type of speech. Speech problems can vary widely. You also have what's called receptive aphasia. Strokes that affect the left side of the brain can cause paralysis of the right side of the body. Also, the right hemisphere problems, strokes that affect the right side of the brain can cause paralysis of the left side of the body. Usually, patients will understand language and be able to speak, but their words may be slurred and hard to understand, which we call dysarthria. Canker. Canshakray. Cancray. All right, so patients, they may be oblivious to their problem. This symptom's called neglect, right? Patients with a problem affecting the posterior aspect of the cerebrum or at the occiput may neglect certain parts of their vision. Generally difficult to detect in the field, but you should be aware of this possibility. Neglect causes many patients to delay seeking help. Patients may be unaware of their problem, that there is a problem, until a family member or friend points out that some part of his or her body is not working correctly. So like all of a sudden you're bumping into walls and stuff, because of that neglect, that vision neglect. Bumping into walls for no reason. We say here around the house, if I bump into a wall, I'll be like, I think I had a stroke. Or we say new legs, stuff like that. Or, damn, look at the gravity all over the place. Look at that gravity all over the place. What, bumping into walls? Yeah. It wasn't a stroke. All right, done with that coffee. I need another one now. That's the first coffee I've had all day. Usually I drink about a pot I had meetings from the time I woke up, and then I had class. All right. So, bleeding in the brain. Intracerebral hemorrhage, what we call that. It may be present with hypertension. Sometimes hypertension is the cause of the bleeding, but many times it's a response to the bleeding. When bleeding occurs inside the brain, the pressure inside the skull increases. High blood pressure in stroke patients should not be treated in the field. Okay? Monitoring the blood pressure and watching for a trend of increasing blood pressure is important, though. Substantial decrease in blood pressure may also occur as the patient's condition worsens. Now, when we're talking about increased blood pressure, how high do you think we're talking? Think we're talking about a slight elevation? Yeah, freaking high. It's going to be high. You'll look at this blood pressure and be like, holy crap. Or you'll pump it up and you'll be like, I don't think I pumped up high enough. Or I can't hear it. We'll pump it up a little bit higher. That systolic may be in the 200s, 220, 250. When you have somebody that's got a blasted high blood pressure, along with a couple other symptoms, that patient's probably having a stroke. Yeah, 200 over. Yeah, concern would be, I'd be like, yep, code gray. So why is it important to recognize that instead of just sending them to the hospital? Yeah. So it's important to recognize that because what hospital are you going to take them to? You need to have You need to take them to a hospital that has what on staff. What needs to be on staff? Neuro. That's right. That is correct. Nero. Wasn't he a Greek philosopher? Spreo was a dragon. Okay. Is this manga? Are you talking about manga? Pearl River Central. Oh, yeah. All right, next page. All right, so conditions that may mimic stroke. 3 conditions may present similarly to stroke. So, hypoglycemia, postictal state, and subdural or epidural bleeding. What's another condition that gets mistaken for stroke sometimes? And facial droop and things like that. Does anybody remember? There you go. Bell's palsy. Good job, fellas. So a patient with hypoglycemia may look like a patient who's experiencing a stroke. A patient with postictal state may appear to be experiencing a stroke. Subdural bleeding and epidural bleeding usually occur as a result of trauma, right? The dura it's a leathery covering over the brain next to the skull. A fracture near the temporal region of the skull may cause an artery to bleed on top of the dura, resulting in pressure on the brain. Because of the source of bleeding is from an artery, the onset of symptoms from epidural bleeding is usually very rapid after the injury. So with subdural and epidural bleeding, the onset of stroke-like signs and symptoms, it may be subtle. So seizures, let's talk about them. Sudden erratic firings of neurons. Yeah. Sudden. Patients experience a wide array of signs and symptoms when having seizures, right? A seizure can be limited to one hand shaking or a metallic taste in the mouth, or it can involve the movement of every limb or the complete loss of consciousness. So here's some types of seizures. So types of seizures, they be classified as general or generalized or partial. Classifications of seizures are outlined on table 19.2 of your book, as you can see here. Tonic-clonic seizures, they present you with the greatest assessment challenges. Most tonic-clonic seizures follow a pattern, traveling through each of the following steps in order, although some patients may not experience every step. First, there we go. Slow it down, Chase. So first you may experience an aura, which is a sensation before a seizure occurs, such as a muscle twitch, an odd taste, seeing lights, hearing a high-pitched noise, loss of consciousness. You'll have the tonic phase, and then the hypertonic phase, and then the clonic phase, which is going to be your rhythmic contraction of major muscle groups, arm, leg, and head movement, lip smacking, biting, teeth clenching. Then you'll have post seizure, your major muscles will relax. You'll have a nystagmus may still occur, eyes possibly rolled back, and then you have the postictal phase. Okay. Which is going to be the reset period for the brain. It can take several minutes to several hours before the patient returns to pre-seizure conditions or pre-seizure level of consciousness. During this time, patients they're often aphasic, right? And they're confused or unable to follow commands. They're very emotional, or they're tired or sleepy. They may be incontinent or have a headache. So gradually the brain will begin to function again normally. What you can also have is what's called What you can also have is what's called a pseudo seizure. They're generalized neurologic event, or it is a generalized neurologic event. You may not notice any different from a tonic-clonic seizure. The root cause of this is going to be of a psychiatric origin. The patient is not intentionally causing this behavior, and the motion that occurs during the seizure is relatively organized. So this is a true pseudo seizure. Not pseudo. Pseudo means what? What does the term pseudo mean? False. That's right. So sometimes we call pseudo seizure like fake seizure, that they're faking it. And when somebody's faking it, sometimes we refer to it incorrectly as a pseudo seizure. A pseudo seizure is a true event that happens because of a psychiatric rooting. So they don't intentionally cause it, which then makes it a pseudo seizure. A fake seizure is just that. It's not a seizure. It's fake. I've had patients where I've sat there and I was looking for the medication. This patient was apparently seizing, and I was sitting there looking for the medication, and the police officer goes, "Hey, she's out again." And I said, "Hey, where'd you say you leave your pills at?" And she literally went from saying, she said, "On top of the refrigerator." Yep. I said, "Okay, thanks." Yeah. So what you have next is absent seizures. So this is present with little or no movement. A child is the typical patient of an absent seizure. Classically, the child will simply stop moving. Usually it lasts no more than several seconds. There's no postictal period, no confusion. It may be brought on by flashing lights or hyperventilation. Excuse me. What you also may have is partial seizures. Simple partial seizures are going to be, it involves sensations of one part of the body when originating in the frontal lobe. It involves altered sensations in one part of the body when originating in the parietal lobe. It may stay in one part of the body or in one body part, or spread from one part to another in a wave. You'll also have what's called a complex partial seizure, which you'll see subtle changes in level of consciousness. The patient can become confused, lose alertness. They may have hallucinations or be unable to speak. Their eyes or head may make small movements. The patient usually does not become unresponsive. Usually they don't become responsive. What you have next is what we call status epilepticus. That's seizures lasting for more than 4 or 5 minutes. The time frame is arbitrary, so we don't really get hung up on that. We're not sitting there going, "They've been doing this for 4 minutes now. This is now a status." It doesn't matter. Some authors have suggested that status epilepticus does not occur until 30 minutes of uninterrupted seizure activity. 30 minutes. That's a long time. So you're going to refer, for these types of situations, you're going to refer to your local protocols or guidelines on how long a seizure can continue before you should intervene. Generally, if we can, depending on the type of seizure, if you want to keep the patient from hurting themselves or anybody else or what have you, but generally, if we can intervene, if we can get an IV, then we try to do that. What's something else that you can do? Something you can do possibly for a patient. Oh, I'm sorry. Sorry. There's nothing we can do. I was about to jump into paramedic phase and talk about atomized midazolam. We don't have to worry about that. Or midazolam through a nasal, intranasally. We don't have to worry about that. So during a seizure, neurons are in a hypermetabolic state. Yes. Yep. If the seizure continues, the body cannot remove waste products effectively or ensure adequate glucose supplies either. The result is neurons being damaged or killed because of this. So our biggest thing is we got to stop the seizure and ensure adequate ABCs the whole time. All right, so some causes of seizures. There are various reasons why a patient can have a seizure. So it could be a congenital disorder, a diabetic type of emergency, fevers such as in infants, or a febrile seizure. Knowing the cause, it does help management. in this. Some seizure disorders, such as epilepsy, are congenital. Others may be caused by high fever, structural problems in the brain, metabolic or chemical problems. Epileptic seizure, it usually can be controlled with medications, certain types of medications. Patients with epilepsy often have seizures if they stop taking their medication or they do not have an adequate dose of that medication. Most seizures are the result of medication non-compliance, right? And you'll hear a lot of things like, I can't afford them, I forgot today, I didn't take it, they don't like the way they make them feel, whatever. So seizures can also result from sudden high fevers, so a sudden onset of a high fever, particularly in infants and small children is where you'll see this at. Just like I said earlier, they're called febrile seizures. It's going to be very unnerving for parents, but generally they're well tolerated by children. Yeah. So you're going to transport the child. The condition needs to be evaluated at the hospital. It may be a sign of encephalitis, meningitis, or some sort of infection. That's why you just don't let them roll off your back. Once everything becomes normal, don't do that. Still follow through. It's not how high the fever goes, but how quickly it gets there. That's the big thing. It's not how high the fever is; it's how quickly it gets to that level. So the importance of recognizing seizures, you must recognize when a seizure is occurring or has occurred, or whether this episode differs from a previous case also. You got to also recognize postictal state and complications of seizures. A patient may turn cyanotic from lack of oxygen in the blood. Could be happening. The seizures may prevent a patient from breathing either. I've always assumed that during a seizure, a patient is not breathing during a seizure. Why wouldn't you think that? You have no control over what's going on with your body. So you got to look at other problems associated with the seizure. So, for example, a patient who has fallen during a seizure may end up with a head injury or something like that. Patients having generalized seizures, they may also experience incontinence. Afterwards, that could be embarrassing for the patient. So you gotta maintain that dignity with a patient when you're doing that. So in a postictal state, once a seizure stopped, the patient's muscles relax and become almost flaccid or floppy, and the breathing becomes labored, fast and deep. You'll hear them. It's almost like they're in a heavy sleep or something like that. In some situations, the postictal state may be characterized by hemiparesis or weakness on one side of the body, resembling a stroke. Most commonly characterized by lethargy and confusion. The patient could be combative, so make sure that you watch out for that. You got to be prepared for any of those circumstances if they happen. If the condition does not improve, you got to consider possible underlying conditions as well, such as hypoglycemia and infection. You should be checking that CBG anyway if you can, right? It's an altered mental status. Check it. All right, let's take a 10-minute break, and then we'll get back onto AMS, or altered mental status. Sound like a winner? It sounds like a winner to me. right, see y'all in a little bit. like I said, boneless chicken wings. It wasn't that good. Only had a few of them. Yeah, it wasn't that good. Had a few of them. Wasn't impressed. The coffee was much better. That, and I had to reheat them. Reheated boneless chicken wings is terrible. Pizza Hut boneless chicken wings are terrible anyway. It'd be Pizza Hut. Unless you're talking about the reheating, which in that case it'd be me. I reheated them. I complain enough. All right, where are we at? We are in need of a screen share. Yeah, the bone photographer. She hates it when I call her that. She gets all offended. Like, oh, that's not all I do. Please hold still. She don't even have to say it. Now the person themselves don't even have to tell them to be still. I was like, you don't even have to do that. It's a little early. Really? You know you're going to get dad taxed.
No, please don't. If you do it, I'm going to come in.
Why are these things so serious?
I don't know.
You're making me look bad in front of... You're making me look bad in front of all these people. That's the knife I used to...
No.
That's the knife I used to dig in all those patients' booties.
No.
I only dad taxed you one. Dad tax. All right. My dessert. One Welch's thing. Ethan, you forgot to close my door, buddy. And get the dog out. All right. On to the next one. So we're talking about altered mental status. So most common neurologic emergencies next to stroke and seizure is what is going to be your altered mental status. It's defined as a patient who's not thinking clearly or who is not capable of being aroused. The patient may be unresponsive or responsive but confused. So some causes of an altered mental status can include hypoglycemia, hypoxemia, intoxication, drug overdose, unrecognized head injury, brain infection, body temperature abnormalities, uncommon conditions such as brain tumors, granular abnormalities, and poisoning can also be some causes. Hypoglycemia, it can mimic the signs. Excuse me. Hypoglycemia, it can mimic the signs and symptoms that's of a stroke and seizures. The patient may have the hemiparesis that we talked about. And the principal difference is that a patient who has experienced a stroke may be alert and attempting to communicate clearly or normally, whereas a patient with hypoglycemia almost always has an altered mental status. Patients commonly, but not always, they take medications that lower the blood glucose. Holy cow! That lower the blood the blood glucose level. So you got to check for and report those medications whenever you come upon that patient. Patients with a decreased LOC may also be able to adequately protect their airway. I'm sorry, may not adequately be able to protect their airway. My bad. And they can also experience seizures as well. So you got to consider the possibility of hypoglycemia in a patient who has had a seizure, especially if the blood glucose reading is low. Extraordinary, amazing that we would figure that out. Seizures, you got to think different type. If you come across a patient that has altered mental status, whether it be from seizure or from whatever, so medically, you almost guarantee you're going to have to get a CBG on that patient. So you got to consider hypoglycemia in all those altered mental patients. After an injury, also look for medical identification bracelets or medications that might confirm your suspicions of that as well. So some other causes that you may see that cause this AMS are going to be hypoxia, unrecognized head injury, severe alcohol or drug intoxication. Consideration is more important because with altered mental status, they may become combative or refuse treatment or transport. Be prepared for the difficult patients of AMS, because those encounters, you need to follow your local protocol for dealing with those situations. Yep, I don't know. I don't know about these new medics. I don't know about them. The county just keeps making them look bad. The county medics are tearing these guys up. I was talking to a couple of them today. I like hearing that. Not that they're getting tore up. I like hearing that our fire medics are doing very well out in the field. So I think that's something to be said about the training differences. A lot of it's fun. It's a lot more fun, I'll tell you that, than being on an ambulance. It's a lot more fun being a medic in a fire department. So something with that too, with the ambulance services. I'll get on a soapbox here for a minute. So something about that with the ambulance services versus your fire that I have seen. This is my opinion. Does not reflect the opinions of some others. Is that now ambulances, or a lot of ambulance companies, especially in the local area, they stay so busy that there's a severe lack of training. The only training that's required is the reoccurring classes that we have every year. Where's the CEU training? Why are we not getting CEU training in? Why are we not having to do these things? And I'll tell you why. It's because they stay so busy. And they don't have, there's being stuck in a truck all day, lack of manning and low pay. Yeah, well, lack of manning is definitely it. Because they're getting ran around. So there's no time to study. So all you are is picking patients up, hauling them away. We need you to keep that basic level of training on your mind at all times. Nobody gets any better. Whereas at your fire department, you may not run as many calls, but you're getting 5 times more training. As a fire medic, we were using platforms like Target Solutions that are CAPC certified, and there were awesome classes. And we would hold classes. We'd meet at one of the stations and hold classes on how to better your patient assessment. We did Zoom classes on ETCO2. We did Zoom classes on this and that. We met live and in person and did classes. It was nothing to go into a fire station and throw a dummy down in front of somebody. Just throw them to surprise somebody. Throw them down and be like, you have a 60-year-old male patient with chest pains, go. And I mean, we would hammer each other constantly. We were better. We were better because we had the opportunity to have more training. And I think that's what's starting to lack, especially in our area, is that opportunity for training. So, which is also a bad thing, because with not having the opportunity for training, your trainers themselves are they're not as educated or as practiced. So you have the blind leading the blind, or you have, you don't know what you don't know type of situation going on. So that's just my opinion, what I've seen. That our fire medics they're starting to way surpass because we have more opportunity. All right, sorry. Got on my soapbox. I will remove myself from my soapbox. If anybody's got an opinion on it, I'm more than happy, or an argument against it. I love it. But what's that thing that changed my mind? If I had my coffee cup propped up on my chair, changed my mind. So that's something that I see, and I think also that our training programs are lacking because of that. I haven't quite figured out. I haven't quite figured out how I feel about the VILT, what we're doing here. I like it because of its convenience and the ability. I have the ability to teach many things. What I don't have the ability to do is that, say we're sitting in class and I feel like there's a concept that we are not understanding, but I could better convey that concept through physical contact or through a practical class. I can't just say, all right, everybody into the lab. Everybody, we're going to have a lab day today, and have that lab day, once a week or what have you, that could really hone or pound in some of these lessons, and which I really like. The hands-on stuff is what I really like anyway. So I think, that's the only drawback I see to that. We have the boot camps, but at that point, we're teaching this much, whereas if you have a live class, I can do a day of lecture, a day of lab, a day of lecture, a day of lecture, a day of lab, a day of lecture, lecture, lab, lecture. Whereas now it's lecture, 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 lab. Lecture, 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 lab. So we don't get as much experience there. I do feel like the full weekend should be something that we look into. Sorry. Back off my soapbox. All right. So hypoxia, unrecognized head injury. Talking about other causes of mental status, altered mental status. Severe alcohol or drug intoxication. We're talking about. People with alcoholism can have abnormalities in liver function, blood clotting, and immune system abnormalities as well. And that could also cause other altered mental status things if you have flare-ups. Psychological issues can adverse effects adverse effects of the medications. People who appear to have a psychological problem may also have underlying medical conditions also. May also have, let me put how many alsos in there. I'll put a few more in there. So infections can cause this altered mental status, like we talk about sepsis. Now, in hospitals, sepsis protocols are huge, which means that coming down the drain, the plumber effect is what I like to call it, the plumber effect. Shit rolls downhill, So in the plumber effect, we should know about sepsis protocols. We should have some sort of sepsis protocols or sepsis recognition. So I think it's important that when we start to process these patients or do our patient assessments, that we recognize that altered mental status with fever, with seizures, with certain types of different maladies, is that we need to realize that this could be a sepsis deal. Let the hospital know on your way there, hey, possible sepsis, so on and so forth, and then they can enact their sepsis protocol to try and cut that off at the pass. There's been a lot of patients in hospitals where sepsis got overlooked. It was overlooked, and patients ended up in severe injury or harm because of it. So, so some of the infections is particularly those involving the brain and the bloodstream. They're life-threatening and immediate attention. That's why we need that recognition. The patient may demonstrate typical signs of infection, particularly if they're very old or young or have an impaired immune system. Something else to look at is drug overdose and poisonings. You got to monitor closely for accompanying respiratory problems with that. Presentation ranges widely from simple confusion to coma. You got to consider altered mental status an emergency that requires immediate attention, even when it appears to be caused by alcohol intoxication or a minor car crash or even a fall. Syncope, which means fainting, right? Fainting episode. Sudden and temporary loss of consciousness with accompanying loss of posterior tone or postural tone. This mainly affects adults. Its potential causes, there's a wide array of potential causes. You got problems with cardiac rhythm and conduction. You got problems with cardiac muscle, myocardial infarction, dehydration, hypoglycemia, vasovagal episodes that can all cause it. So something with syncopal episodes as well is that once you have the syncopal episode and you come back to, that's your body's way of that reset. Turn it on, turn it off, and turn it on again, type deal. The IT portion of your body is turning the machine off and turning it on again. Sometimes you'll have the syncopal episode, and when you come back to, everything's back to normal. So it's a reset. All right, headaches. So tension headaches, migraines, sinus headaches are the most common causes or most common types of headaches. These are not medical emergencies. Tension headaches are not, migraines are not, sinus headaches are not. They're common, they're not medical emergencies. Now given, they may feel like a medical emergency, such as like a migraine or something like that. It may feel like a medical emergency. It is not. Tension headaches are caused by muscle contractions in the head, neck, and are also attributed to sex. Stress. Contributed to stress. I was way off on that. Excuse me. Stress. The pain is usually described as squeezing, dull, or as an ache. Migraine headaches is thought to be caused by changes in the blood vessels, size, and the base of the brain. The patient may experience aura and unilateral focused pain that spreads over time. The patient often describes the pain as throbbing, pounding, pulsating, and it may have nausea and vomiting included in it. Patients prefer dark, quiet environments when they have these migraine headaches, and they can last for several days. Cluster headaches. It's a rare vascular headache that occurs in groups. So these may recur for days and then stop entirely. Minor pain starts around one eye and intensifies and then spreads. You have a feeling of anxiety with these cluster headaches as well. So Also, what you can have is your sinus headaches. It's caused by inflammation or infection within the sinus cavities of the face. The pain in the superior part of the face increases when you're bending over forwards. You'll feel that increase. So let's talk about the patient assessment for these. The brain is an organ most sensitive to fluctuating levels of oxygen, glucose, and temperature, right? It responds to alterations with changes in function. The brain is relatively resilient to internal environmental changes also. The key to identifying a neurologic problem is to look for both obvious and subtle changes. So starting off with the scene sizing up. First off, you're going to look for scene safety. Take your standard precautions, gloves and goggles. Tonic-clonic seizure patient may be incontinent, so you may even want to consider a gown if you need to. So look for clues at the scene as to what may have happened. Your surroundings right. As an AEMT, it may require additional assistance for patients with altered level of consciousness. Request additional resources early in the call. Consider the need for spinal precautions because we don't know, if this patient fell, were they standing when this happened, were they, what was going on. Consider the mechanism of injury or history of present illness for this. Look for signs of potential trauma. Also, look for indications of a previous medical condition such as diabetic supplies or medical alert tags or evidence of a seizure. Up next, you're going to go into AEIOU TIPS, TIPS, mnemonic. It's helpful remembering causes of decreased LOC. Does anybody remember that? AEIOU dash TIPS, TIPS. Does anybody remember what that stands for? Crickets. Crickets, crickets. That's the first you've heard of it? Okay. So, AEIOU tips is going to be like your coma diagnosis or altered mental status diagnosis. So A is for alcohol, acidosis, ammonia, and arrhythmias. E is for endocrine, electrolytes, and encephalopathy. I is for infection. O is for oxygen or overdose of opiates. U is for uremia. T is for trauma, temperature, and thiamine, like as in Wernicke-Korsakoff. Then you have I, which is insulin. And then you have, I is insulin. P is poisoning and psychiatric. S is stroke, seizure, syncope, shunts, and something else. I can't remember, but I think that's a lot. It's very helpful remembering causes of decreased LOC. It may actually help you with your patient assessment as well. When you're assessing your patient with an altered mental status, consider the causes listed in Table 19-4 in your book. 19-4 in your book. So you're going to examine the scene to ascertain a number of patients. How many patients do you have? If the time it takes to get to the nearest stroke center is greater than 1 hour, then request air medical transport early if available. If the time it takes to get to the nearest stroke center is greater than 1 hour, then request air medical transport early if available. Sound good? Oh, look. Got some posturing there. All right, so you're going to form a general impression of the patient. Note the patient's body position and the level of consciousness. Observe the seizure activity. The seizure will probably be over by the time you arrive. If the seizure is still in progress, watch for status epilepticus, which can be a potentially life-threatening condition, right? You want to determine the LOC for anyone with an altered mental status. If the patient does not respond to verbal stimuli, consider whether the patient is displaying an abnormal posturing, like you see here, which may indicate severe brain dysfunction. So up top here, you have decorticate positioning or posturing. The patient contracts the arms and curls them towards the chest, usually. And then you also have decebrate posturing. The patient, again, points the toes. They point the toes, and but now it extends the arms outward and rotates the lower arms and the palms in a palms down manner, like you see here, or what we call pronation. It's the most severe finding. This is a more severe finding than decorticate. So decebrate, or what I used to call decebrate, because it looks like they're celebrating. Sometimes you'll see them with their arms up here, celebration, or they'll have extension. There's extension. So, weird way of remembering it. Which one's which? All right, so airway and breathing. A, B, right? A and B. I'm looking. We had a decebrate posturing back in January. Patient had been in the woods hunting for about 10 hours. Nobody could get in touch with him for over 6 hours. He had a massive bleed, and we didn't realize until we got him in the ER and was cutting his waders off. He ended up passing a few days later. Was the first time I'd ever seen it. Yep. Yep, he was in a bad way. All right, so airway and breathing, AB. We're in the primary now. So focus on the airway and breathing on arrival. If the patient is unresponsive and apneic, immediately assess for pulse and begin chest compressions if they're pulseless. Easy, right? Unresponsive, apneic, pulseless, chest compressions. Stroke patients may have difficulty swallowing and may choke on their own saliva. Continually reassessing the airway for patency and respiratory rate and quality is going to be important. If the patient needs assistance maintaining an airway, consider an oropharyngeal or a nasopharyngeal airway. You can provide suction and position the patient to prevent aspiration. If the patient cannot protect his or her own airway, place the patient in the recovery position to prevent aspiration. The seizure patient may clench his teeth or have trismus. That's what we call clenching, trismus. And and they're going to require sedation to get a good airway. So you're going to have to request a paramedic backup for those difficult airways. Assess the patient's breathing. Generally, the greater the deviation from normal, the more severely the nervous system is going to be affected. Unless you suspect cervical spine fracture, you can elevate the head 30 degrees. Provide ventilatory support. And why do you think we elevate the head 30 degrees? Has anybody ever read that study of why we elevate 30 degrees? I want everybody to look that up. Not right now, but I want everybody to look that up. Is why would you elevate the head 30 degrees? And let's do it. Let's make it to where you can find an easy answer. So elevation, 30-degree elevation of the head during CPR. And so that'll explain, why we do that. It's a pretty good little study. And then also the adjunct, the CPR adjunct that we would use, or tool that we would use on a BVM that would also go with the 30-degree movement. That's pretty good stuff. How it promotes recruitment and all this. I'll start talking too much about it. So provide ventilatory support at 10 to 12 breaths a minute, right? Unless the patient presents with signs of cerebral herniation. Okay? So ventilatory support unless the patient presents with herniation. Because if at that point, if you're starting to do that, then you could create more of an issue if you start ventilating that patient or hyperventilating that patient or what have you. So circulation, you're going to begin by checking the pulse, right? If no pulse is found, immediately begin CPR. Begin with chest compressions and attach an automated external defibrillator, an AED. If the patient is responsive, determine if the pulse is fast or slow, weak or strong. Evaluate the peripheral and central pulse pressures. Okay. Vital signs will provide evidence of increased pressure within the cranium. So blood pressure rises, heart rate decreases, respiratory rates become irregular, and pulse pressure widens. The set of conditions known as Cushing's reflex, Triad, reflex, whatever you want to call it. Cushing's reflex, that's actually the proper term for it. And is the opposite of what is expected in shock. The opposite of what is expected in shock. So Cushing's reflex. So transport decision. Unstable patients with inadequate or deteriorating ABC should be transported immediately to the ED. Focus on stabilizing and maintaining the ABCs. There is more time to evaluate and care for patients who are stable. Rapid recognition and transport to an appropriate facility may prevent permanent damage and decrease the mortality rate, which is a good thing. If the patient is suspected of having a stroke, rapidly transport the patient to a stroke facility or a facility with a stroke team in place. Give as much advance notice of arrival as possible to the emergency department. Relay the information you obtained to the receiving hospital, including the time that the patient was last seen normal and the findings of your neurologic examination and the time you anticipate arriving at the hospital. So some history taking. You're going to investigate the chief complaint. So obtain the history from the patient if they're stable, if they're in stable condition and with minor complaints. If the patient is unresponsive, gather any history of the patient's present illness from family members or bystanders. If no one is around, quickly look for explanations of an altered mental status of why it's going on, possibly. If a responsive patient, ask him or her what happened. Evaluate the patient's speech while you're doing this. Look for any obvious trauma or explanations. If you suspect the patient may have had a seizure, then you need to notate that. If the patient has a headache, try to determine the patient's level of stress possible infections, and a history of headaches. Stroke patients could also Stroke patients can also experience headaches. So perform a rapid scan if you suspect more complicated problem, and then from there, you're going to gather a sample history. Remember that time is critical in a neurologic emergency when you're gathering all this history. So make a special effort to determine the exact time that the patient last appeared to be healthy. Obtain a full list of all the medications the patient has taken. Patients who've had a stroke may appear to be unresponsive and unable to speak, but they may still be able to hear and understand what's taking place. So make sure that you be cognizant of the way that you're speaking around the patient. Try to establish that effective communication as well. Your history should reveal if the patient has had a history of seizures. So find out if this episode has differed from previous episodes and what medication the patient takes for it. And if the patient doesn't have a history, a serious condition could probably be suspected from it. A lot of times, where they're getting at here, I do believe, is a lot of times you start thinking more along the lines of possible brain tumors. So your secondary assessment, you're going to perform a secondary assessment as soon as possible. Look for any potential cause of neurologic signs and symptoms. Note whether the patient is incontinent. Urinary and fecal incontinence are common findings with seizures or syncope. So that's, and like we said, you may show up on scene and they be normal again. But if you can notate the incontinence, then you may have figured out then, hey, you did have a seizure, possibly. The patient should also be assessed for any types of injuries, include like head lacerations, shoulder dislocations, bitten tongues, or long bone fractures in some cases. The rapid identification, knocking on that, the rapid identification of a stroke is imperative, so the sooner the better. You're going to perform at least 3 key physical tests on the patient you suspect of having experience. We talked about it. We're going to do the facial movement, the speech, the arm movement. If any one of those are positive or abnormal, you should assume the patient experiencing a stroke, right? So there's a couple of ways. You have the Cincinnati pre-hospital stroke scale, and then you also have the Los Angeles pre-hospital stroke screen. Is shown in 1906. So one of those checklists is going to be very comprehensive, and if you meet certain criteria of that very comprehensive list, you are definitely stroking out. Whereas you may not be stroking out with the Cincinnati stroke scale. In the Los Angeles, if you meet those criteria, you're having a stroke. So the blood pressure is most closely monitored in any patient with a potential ICP problem. Frequent assessments become even more essential when a decrease in blood pressure is also present. Changes in pupil size and reactivity may indicate herniation. So look at that. So, like we said before, you're going to obtain that pulse rate, rhythm, character, respiratory rate, and character. I'm sorry, you're going to pulse rate, rhythm, and character of the pulse, and then you're also going to take into account respiratory rate, quality, and the degree of distress of the breathing, blood pressure, skin color, temperature, condition, blood glucose level, and pupil size and reactivity. Going to be pretty important findings. The glucose levels of less than 10 mgs per 10 mgs per dl are incompatible with brain functioning and typically lethal. So any glucose level less than 10 is bad juju. You're going to determine the pulse ox reading, and then also, guess what else? This is a sick patient. And what have I said 100 million times about what is the gold standard that we're going to get on these patients? This is a sick patient, so we want to put what on this patient? TCO2 levels to suggest inadequate ventilations. Capnography. And then from there, you're going to follow on with your reassessment. Oh, look at there. GCS scores. GCS scores. I agree. You know, every time we mention capnography, it's almost like you have that line saved on a notepad or something, because you say that every time we talk about ETCO2. I agree. I do agree. So you're always going to provide that emotional support. For patients who experience a seizure, give a description of the seizure activity in your documentation. Document the onset and duration of the seizure. Record any interventions that you performed and the patient's response with those findings. Continue that with your reassessments. So a patient with stroke, seizures, hypoglycemia, or hypoxia typically show identifiable signs or symptoms, and treatment options are readily available. Most of your interventions are going to be based on your assessment findings. Your best treatment is determined by performing a thorough assessment and maintaining your ABCs, right? So there are two medications that are available for pre-hospital treatment of hypoglycemia, which are dextrose and glucagon. In patients suspected of experiencing a stroke, and only if the patient's blood glucose level is low, give your dextrose. Consider the administration of glucagon for hypoglycemia as an alternative. If you can't check the patient's blood glucose level because of equipment failure, you need to be more cautious in administering dextrose. So proceed with additional doses of dextrose cautiously based on responses to previous doses. So hypoglycemia is more lethal than hyperglycemia. When administering intravenous dextrose in the form of D50, you must establish an IV with a large bore catheter within a large vessel because D50 is so viscous. Okay? Ensure that the IV line is patent before you attempt to give the D50. If you cannot obtain a good vascular access, administer 0.5 to 1 milligram of glucagon. 0.5 milligrams to 1 milligram of glucagon subcutaneously or intramuscularly. So sub-Q or IM. 0.5 to 1 milligram of glucagon. If the blood glucose level remains low, repeat the glucagon for a maximum of 3 doses. All right. Oral glucose administration is another option for the patient with a decreased LOC. who can protect their own airway. They got to be able to swallow it. They got to be able to swallow it. You don't want them choking on it. Ensure patients do not aspirate. You want to make sure of that. So you may want to make sure your suction battery is full. You need to make sure of that anyway every day. But go ahead and make sure. Ensure, or currently there's no safe way to lower a high blood glucose level in the field. Provide emotional support for the patient and the family. Use a calm, reassuring voice to show that you're there to help them. Got it? All right, let's go ahead and take a quick 10-minute break. Pause for the cause. A quick 10-minute break, so a 10-minute break.
You're muted again.
Good Lord. I need something set up that, like, after the 10-minute break, it, like, unmutes it automatically. I have to mute it because I don't want y'all hearing the way I talk to my kid. No, I'm kidding. So stroke. Start over. So stroke. You want to assume that a patient with TIA or stroke symptoms is experiencing a stroke always. You're with that patient. You're going to administer supplemental oxygen. You're going to establish that IV access and obtain blood samples for analysis. Some patients have that in the CBGs. Yes, that's going to be an important part. In here, it's talking about obtaining blood samples for analysis. Some places do ask pre-hospital in the pre-hospital setting that we take the vials of blood so they can get D-dimers on it or what have you. Locally, that doesn't happen, so you just got to look at your protocol. I think it's a good practice, but you have to, at that point, train people to, consider the coagulation factors and all this good stuff. But I think it would be a head start if we did things like that. So you're going to transport the patient to the closest appropriate facility for evaluation. A CT is needed for a physician to determine whether the bleeding is in the brain. In patients who are unresponsive or demonstrate other signs of increased ICP, administer fluids as needed. Okay? Because you don't want to create more issues, so just as the need is. Unless you're concerned about a possible spinal injury, you want to elevate the patient's head 30 degrees. Okay? And ensure that the airway is clear. Watch for the seizures and call early for paramedic backup. It's important to monitor the blood pressure very closely. And then, excuse me. You're going to do a frequent assessment if anything becomes more critical in that aspect. So carbon dioxide and oxygen levels are important in patients with increased intracranial pressure. So low oxygen levels markedly increase the mortality rate or the mortality in patients with brain injury. So you don't want to hyperventilate these patients. Don't hyperventilate them. So consider the AHA. There's an AHA algorithm out there for stroke patients. Consider using that. It shows goals of treatment for patients with suspected stroke. So you want to make sure that you go over those. Time is probably one of the most essential factors that you're going to have. And that last time they were seen normal. In hemorrhagic strokes, the more the patient bleeds into the cranium, the greater potential for increased ICP and brainstem injury. That's why we talk about the fluids factor. Aspirin should be administered only after CT or MRI imaging has been completed in the hospital. Only after. So CT or aspirin should be administered only after CT or an MRI has been completed in the hospital. So there's the AHA sheet there. It shows the adult suspected stroke algorithm for the American Heart Association. So screenshot it if you want to. All right, moving on. So TIA, talking about care, emergency medical care continuing with TIA, or transient ischemic attack. You're going to begin with standard care. You're going to follow the same management guidelines for a stroke. The close neurological assessment is going to still be needed. Strongly encourage the patient to be, they're going to want to, a lot of them are going to want to cancel, they're going to want to get a refusal. You want to strongly encourage that they get transported because, like I said earlier, that TIA could just be a pre-indicator of a coming stroke. So if the patient refuses, you need to appeal to the patient's family as well. Encourage the patient to seek medical care soon after. If they're just going to refuse, encourage them to seek some sort of medical care soon after. And then reinforce that TIA again is a warning sign of a serious or potentially fatal problem with blood vessels in the brain. So seizures. In most instances, patients who have had a seizure require definitive evaluation and treatment in the hospital. In the hospital, blood levels of seizure medications are checked to ensure that patients are receiving the correct dose for their medications. Patients having had their first seizure and patients who say that this seizure is different require immediate evaluation to rule out other life-threatening conditions. You want to administer oxygen to these patients that have experienced these seizures. So with a recurrent seizure, you need to protect the patient from further injury and manage the airway after the seizure ceases. For patients who continue to have a seizure, or as in a status epilepticus, you need to make sure you suction the airway, provide PPV or bag mask ventilations, and transport quickly to a hospital. If you have the option to rendezvous with a paramedic, you should do so. So it's important to gain IV access as a medication route, even if the fluid resuscitation is not needed. Why is that? Because if you're going to do a paramedic rendezvous, or if you're going to get them to the hospital, that medication route is going to severely enhance their chances of survival or of mitigating the issue, because then at that point they can give them some sort of they can give them a narcotic or something like that to bring them out of the seizure. You may need to provide spinal immobilization if a trauma is involved and it cannot be ruled out. So you may need to do that. Depending on your local protocol, you should assess and treat for possible hypoglycemia, like we talked about. That is an altered mental status. Look for things like tongue lacerations and bleeding that may create an obstruction or lead to aspiration. So look for those things. With recurrent seizures, protect the patient from further injury and manage the airway as needed continually. If you're treating a child whom you suspect of having a febrile seizure, you should attempt to lower the body temperature. So, no covering up, things like that. Be careful not to make the patient shiver, though. If you make them shiver, that causes issues also. Syncope. Fainting. You're going to begin with a standard of care. You're going to determine whether the patient experienced trauma during the fall, if they fell out. You're going to take C-spine precautions if they're needed. Focus on the CBG and likely cardiac causes. Look at those. So something else you're going to do is obtain an orthostatic vital sign. You're going to provide that supplemental oxygen, and you're going to gain that IV access. You're going to do it. Also, provide the emotional support as usual. Syncope can be life-threatening. It can be a sign of life-threatening medical conditions. If you need to, call that paramedic backup. Call early if you're going to do it. All right, headaches. So be cautious of some of your headaches because that can indicate a serious problem. Give your usual standard of care. Ask the patient about any type of medications that they take. Many patients during this time appreciate a darkened or quiet room, so you may not want to use the lights and sirens while transporting. Cut the lights down inside of the ambulance as well. All right. That is the end of that slide. Does anybody have any questions or anything like that about anything we covered tonight? No? Yes? Maybe? Okay. So, I got the test, I got the quiz in there. So let's be sure to get the quiz. I will give you the code, the secret code. All right. So the code for tonight is going to be 5436. 5436. 5436. That's it. 5436. 15 questions, 16 minutes. Y'all know the drill. I had my first college algebra test yesterday, and it was a no grade. It's for no grade, just seeing how much we know. It has literally been roughly 21 years since I've done any type of algebra, so I had no clue. I went through it. I think I had a piece of one question right out of it, so it was like 8 questions. We had 20 minutes to do it, and she was like, "Don't worry about it. People make the average grade for this is 5%. Don't fret about it. It just lets me know if you know anything of this." So I turned mine in 0% or like 0.1%. And I was like, yeah. And so most of the students in my class today, they're younger students, high school, just got out of high school, what have you. So it was pretty interesting. They were, we're not allowed to have graphing calculators in there, but we can use calculators. Hold on one second. Let me quit recording before I start jammering on. All right, I'm gonna stop recording. Does anybody have any questions about any of this before we go? Okay. Any questions about upcoming quizzes or the discussion that's going to be due on Friday? Anybody take a look at that yet? Any questions? Okay. If not, I'm going to stop recording